First.
Assalamu alaikum. I'm Dr. Shakeela Younus. I am here to present on anatomy of female genital tract, physiology of menstrual cycle, and gynecological examination history. I have done my MBBS from Dow Medical College, and I passed my membership and fellowship exams from Pakistan, and I did my MRCOG from UK and MRCPI from Ireland. Right now, I'm working as consultant OB-GYN in Saudi Arabia. So let's start with our today's topic. It's a bit lengthy. I will try to catch up all in, try to discuss only the important things for all three topics.
Dr. Shakeela, can you make it slideshow?
Yeah, I will make.
Thank you.
So these are the references. I have gone through all the basic books, Atlas and Google search for the pictures, especially because pictorial is better. So starting with anatomy of female genital tract, starting from external genitalia. Vulva, it has different parts. Mons pubis, it is a pad of fat covered, covering the symphysis pubis, and it is covered by skin and hairs. Then clitoris, it's erectile cavernous structure below symphysis pubis, and small glands and two corpora cavernosa. Then labia majora, outer two lips, they are covered with skin and hairs, and then labia minora, thin inner fold. Hymen is a membrane situated 2 centimeters from vestibule. It demarcates external and internal genital organs of the female. And Bartholin's gland, they are great vestibular glands. They secretes mucus during sexual excitement. And its duct is 2 centimeters long. Its importance is it can become clogged and make Bartholin's abscess or cyst. Vestibule is an inner aspect of labia minora and furcate. Structures that opens into vestibule are urethra, two Bartholin's ducts, and vagina. External urethral meatus, vestibular bulb, and Skene's ducts. Skene's ducts are the glands that opens around the urethra to keep it moist. These are the different types of hymen. All you can see all in every patient. This imperforate hymen, it's especially the abnormal one. Patient present usually with the primary amenorrhea, and we need to do cruciate incision to release the periods. Blood supply of vulva, arterial supply for internal pudendal artery branches from femoral artery and anterior part of superficial and deep external pudendal. Venous drainage, they accompany all venous plexus, accompany with all the arteries. Lymphatic drainage of vulva, usually superficial and inguinal and deep inguinal lymph nodes, and lymphatic channels that pass through deep pelvic, external iliac, internal, and para-aortic lymph nodes. Nerve supply, it comes from pudendal nerve mainly, sacral 2, 3, 4, and additional sensory from ilioinguinal nerve, posterior cutaneous nerve of thigh, and genitofemoral nerve. Vagina is a fibromuscular tube, starts from vulva to the uterus. It's 8 to 9 centimeter long anterior wall and 10 to 11 centimeter posterior wall. It has fornices along with the cervix, anterior, posterior, and lateral fornices. What are the anatomical relations of vagina? They are very important. Excuse me. Anteriorly, upper third, you can see here, upper third of vagina, it relates to trigone of bladder, urinary bladder, and lower third related to urethra. And posterior wall of vagina, upper third related to pouch of Douglas, middle third related to rectum, and posterior third, lower third, it is near to the perineal body. Laterally, all the muscular layers, levator ani muscle, lateral fornix, and especially importance is ureter that passes through cardinal ligament 1 centimeter lateral to vagina. It's really important when we are doing a vaginal hysterectomy, especially when we are applying clamp and suturing at the lateral fornix while removing the uterus. Then vagina is supported by different supports, ligaments, pubocervical anteriorly, transverse cervical or Macken rods laterally, and uterosacral ligament posteriorly. Levator ani muscles, pubo-vaginalis part, triangular ligament, perineal muscles, and vaginal fascia that condenses and make anterior pubovaginal and posterior rectovaginal fascias. This is how it's supported. Blood supply, again, arterial supply from vaginal artery and middle rectal inferior rectal artery, and venous drainage, all the plexus, they make a plexus and drains into internal iliac veins. Vaginal lymphatic drainage and nerve supply. Lymphatic drainage, again, upper third, it drains into inguinal, lower third, it drains into inguinal, upper third drains into cervical lymph nodes, and middle it goes both up and both cervix and vaginal directions. Nerve supply is sensory fibers from pudendal nerve. Pudendal nerve is important here. Again, applied anatomy is like why we are learning this anatomy. Especially patient when they are presenting with vaginal prolapse, we should know that these are the vaginal supports that loosen and weaken and make a prolapse. So if it is descent of anterior vaginal wall, it makes histocele or urethrocele. Descent of posterior vaginal wall, it makes rectocele, anteriocele, and descent of vaginal vault after hysterectomy, that we call it as vaginal vault prolapse. Posterior fornix, it's a pouch of Douglas from where we can do cultosynthesis and drainage of pelvic abscess. You can see here. And lateral fornix, again, its surgical importance is ureters that lies 1 to 2 centimeters lateral to it. So while clamping during hysterectomy, it can be injured. So we should take care of it. Pudendal nerve block, because almost all the vulva and lower vagina, they are supplied with pudendal nerve. So we can use a pudendal block with lidocaine at the level of ischial spine to anesthetize it to perform multiple operations on vulva, episiotomy, and apply forceps during delivery. Now come to the uterus. It's a pearl-shaped muscular organ, 4 into 2 centimeters, usually antiflex, sometimes retroflexed uterus, slightly larger in multiparous patient than nulliparous. It has different parts. Again, the body, cornu, 2 cornu, and the fundus, and then cervix. 3 structures that are attached to cornu are round ligament here, tubes, and ovarian ligament. Isthmus is very important. Obstetric point of view, it's an area 4 to 5 mm, like ½ centimeter in length, that lies between anatomical internal os. You can see here anatomical internal os above, and in histological internal os below. So isthmus expands during pregnancy in 9th month to 10 centimeter to make lower uterine segment. This is the area where we perform surgery by doing phalansteal incision or transverse low uterine incision. Cervix, again, it's 2 to 3 centimeters elongated lower part of the uterus. Cervical canal is cavity that communicate above with uterine cavity and internal os. Cervical mucosa, it has 2 ridges. Uterus kept anteverted by certain ligaments. Anteversion is uterus that inclined anteriorly, and anteflexion is the body of uterus that flexes along over the cervix. What are the relations of uterus anteriorly to bladder and vesico-uterine pouch? Posteriorly, pouch of Douglas, you can see here, and laterally broad ligament. Supravaginal cervix relations: anteriorly Younus bladder, posteriorly it forms pouch of Douglas, again laterally, half-inch lateral to internal os, ureter crosses uterine artery, ureter below the uterine artery. Uterosacral, cardinal, pubocervical ligaments are the attachments to its posterior lateral and anterior cervices and keep it in the place. Then histology: uterus has three layers: endometrium, myometrium, and perimetrium. Endometrium is lined with the columnar epithelium. It undergoes cystic changes during hormonal changes during menstrual cycle. And then myometrium, it has three layers: outer longitudinal muscle, inner crisscross muscles, and middle crisscross, and inner circular muscle layer. Histology again of perimetrium: anteriorly it is firmly attached to whole body of uterus until isthmus, where it becomes loosened and make vesico-uterine pouch. This is the pouch where we opened and reflects the bladder down. Posteriorly, it firmly attached to body until pouch of Douglas, and laterally to broad ligament. Histology of cervix is important. Endocervix, muscular layer, it has two muscular layers: cervix, longitudinal and circular. And endocervix, it's lined by columnar epithelium, and ectocervix is lined by stratified squamous epithelium. Importance is the change of stratified squamous epithelium to columnar epithelium. This zone that is called a transitional zone, 1 to 3 mm, from where we do pap smear, and here the changes occurs for cervical abnormality. Blood supply of uterus: again, arterial supply from uterine arteries that arise from anterior region of internal iliac, you can see here, and at the base of broad ligament crossing above the ureter, half-inch lateral to supracervix, you can see here. Then it makes two branches, ascending and descending branch, to supply the uterus. Ascending branches passes up for tortuous manner, and descending branch supplies to lower cervix. Venous drainage: makes all the pampiniform plexus in the broad ligament and drains into uterine and ovarian veins. Lymphatic drainage, it's very important, because if a patient has malignancy, so how to follow? If it is a fundal part, they will go to para-aortic lymph nodes. Cornual part go to lymphatics around the ligament, and body to external iliac lymph nodes. Then cervix, it has two groups: primary group, paracervical, parametrial, obturator, internal. These all are pelvic group, and they all drains into common iliac, para-aortic, lateral sacral lymph nodes. Nerve supply: it's usually insensitive to the pain. Cervix and body are relatively insensitive to touch, cutting, and burning. Cervix is sensitive to dilatation, and body is sensitive to distension. Innervations are sacral 2, 3, 4, parasympathetic from parasympathetic, and sympathetic from thoracic 5 and 6 motor, and thoracic 10, 11, 12 are sensory nerves. These all reaches to uterus through branches from inferior hypogastric plexus. Fallopian tubes: these are 10 centimeter inland tortuous tubes, lie in free upper part of broad ligament. They blend medially with cornu of uterus. Laterally, they are free outer and end backwards towards the ovary, and their lumen communicate between uterine and peritoneal cavities. It has 4 parts. The tube, it has 4 parts: interstitial, that enters or pierces the uterus, and it's the thinnest part. And then isthmus is 2 centimeter, that is more of a muscular layer. And then ampullary part, that is a dilated thin part. Here usually fertilization occurs. And then infundibular part, that is a trumpet shaped part that covers the ovary and take ovaries, pick the ovaries from here and fertilization occur, or just travels the ova towards the uterus with the femoral movement of the tube. What are the tubal functions? Again, ovum pickup, transport of ova, and fertilization in and production of secretions and capacitation of sperm nutrition. Anatomical relations, they are not that important for during surgery for ovaries, because for the tubes, because they are very tortuous and loose parts. Histology of fallopian tubes is important. Again, it has 3 layers: mucosa, endosalpinx, arranged in 4 to 5 main longitudinal ridges, and it lined by columnar, partially ciliated epithelium. These cilia, they help ova to travel. And muscular layer, longitudinal, inner circular, and a serosa peritoneal covering. Blood supply and lymphatic drainage, again arterial supply from uterine artery and ovarian artery, and venous drainage, and right ovarian, left ovarian veins that directly drains into right to inferior vena cava and left to left renal vein. Lymphatic drainage to para-aortic lymph nodes and ovarian lymphatics. Nerve supply, sympathetic and parasympathetic fibers. What is the applied anatomy? Tubal pain, usually patient will complain pain over lower abdomen, half an inch above mid-inguinal point. Ovary is an almond-shaped, a whitish structure, 3 to 2 centimeter. Surface is pearly white usually, and it has different attachments. Meso-ovarian, infundibulopelvic ligament, and ovarian ligament. Meso-ovarian peritoneal fold that suspend ovary to back of the broad ligament. Infundibulopelvic ligament that we usually remove when we are doing salpingophorectomy. We remove this infundibulopelvic ligament that suspends upper part pole of ovary to lateral pelvic side wall, carries ovarian vessels, nerves, and lymphatics. Ovarian ligament attaches lower pole to cordon of uterus. Anatomical relations important is inferiorly it is in ovarian fossa where ureter passes and interiliac vessels are passes. So during doing salpingophorectomy, there is a chance that while you are clamping it, you can injure the ureter and make hematoma. So be careful in that. Now ovary. Ovary, it has 3 parts: cortex, medulla, and hilum. Cortex, medulla, and hilum. Medulla, it is central court of ovary surrounded by cortex, continues with hilum, and cortex, it is the main part, outer active part that produce hormones and oocytes and primordial follicles. They develop and ovulation happens here. It has condensed connective tissue stroma, then hilum where the vessels and lymphatics are traveling. Blood supply of ovary, ovarian artery and branches from uterine artery, and venous drainage, they accompany with the arterial supply, lymphatic drainage to para-aortic lymph nodes, and nerve supply, it is usually insensitive, except when you are doing squeezing on PV examination. Sympathetic, parasympathetic nerves from thoracic 10 and 11. Now come to ureter and its significance. Ureter, these are the 2 narrow muscular tubes, 25 centimeter in length, runs from both kidneys retroperitoneally down and enters in pelvis at the level of pelvic inlet. The ureter enters pelvic above bifurcation of common iliac artery anterior to sacroiliac joint here. In pelvis, it runs downward and lie in front of interiliac artery. So it's important when you are doing any surgery in the pelvis. Pelvic part of ureter, again, at the base of broad ligament, It runs medially forward. This is ureter. It runs medially forward through perimetrium until it reaches 1 centimeter lateral to the cervix, where it passes below right angle of uterine artery. Ureters then passes forward through ureteric canal in upper part of cardinal ligament, closely related to lateral vaginal fornix, to enter trigone of urinary bladder. Now, three places are very important when we are doing hysterectomy. One is it is near infundibulopelvic ligament. Second, near cervix, where we are doing transverse cervical ligament and uterine, especially uterine vessels, clamping and cutting. And third is cervical stump, when we are separating the cervix from vagina, or removing the cervix and ligating the cervical stump lateral fornix. So these are the three parts where we can injure the ureter. So we should be very careful. So these are the blood supply. Wherever it travels, it takes supply internal iliac, uterine artery, vesicle, and vaginal artery. Applied in anatomy, again, I already discussed. During hysterectomy, we can injure it during clamping in fundibulopelvic ligament. Again, it is a repetition. Then during clamping the ureteric arteries, that is passes below uterine artery 1 centimeter lateral to the cervix. During clamping the vaginal angles and parametrium 1 centimeter lateral to vaginal vault. So this is very important to know about pelvic anatomy of ureters if you are a gynecological surgeon. Uterine and cervical ligaments, broad ligament, round ligament, and ovarian ligaments. We already know broad ligament, it is a sheet, double sheet, the perimetrium that covers the whole of the lateral pelvic walls, and the uterus and lateral pelvic wall. Its upper part forms infundibulopelvic ligament, in which ovarian vessels travels where the way to the ovary. What are the contents? Ovarian vessels, round ligament, uterine vessels, ureter, parasympathetic, parametrial, lymphatic, sympathetic, parasympathetic nerves, and all the paraphron, epiphron, hydrated cyst of Pogagni, all these embryological remnants, they can be there. They can found there while you are doing procedure. So you can expect all these contents in broad ligament. Round ligament, again, it's a fibromuscular ligament attached to uterine carno, keep the uterus anti-flexed. It pulls the uterus forward. And ovarian ligament, it's a fibromuscular ligament, attaches inner outer pole of ovary to cornu of uterus. Cervical ligament, they are very, very important while doing hysterectomy again, or any cervical surgeries. It is bound anteriorly by pubocervical ligament, pubocervical fascia that condenses make pubocervical ligament. It attaches posterior to sacrum by uterosacral ligament, and laterally to the pelvic wall by transverse or cardinal ligament, or we can, there is another name, Wackenroth's ligament for it. Pelvic floor is made up of multiple tissues. It has, we have a list: pelvic peritoneum, extraperitoneal fat, cellular tissues, levator ani muscle, triangular ligament, perineal muscles, and subcutaneous fat tissue, and skin. Pelvic diaphragm, it's made up of all levator ani muscle and covering fascia above and below. In midline, it pierces with urethra, vagina, and rectum or anal canal. Levator ani muscle, it has 3 parts. Parts, they divide according to its attachment. So iliococcygeus mean it where it attaches to coccyx, ischiococcygeus, then pubococcygeus. They pubococcygeus, it has three parts again: pubourethralis, vaginalis, and rectalis. So they keep them in place and help to maintain the continence. Now start with menstrual cycle physiology. We finish with anatomy. Menses are the complex interaction between hypothalamus, pituitary gland, and ovaries and endometrium. Ovaries are functional morphological changes that results in follicular maturation, ovulation, corpus luteum formation, and changes in hormones. Endometrium, it functions and morphological changes either to prepare for conception or shedding of menstruation. So ovarian cycle, endometrial cycle, and a hormonal cycle. So here, uterine changes, ovarian hormone changes, and gonadotropins. Gonadotropins, they release from hypothalamus, they stimulate anterior pituitary. Anterior pituitary releases follicle stimulating hormone that and that affects the ovaries, and ovaries releases estrogen. Estrogen affects the endometrium, and ovaries starts making egg from primordial follicle, primary follicle to matured. Ovulation happens in mid of the cycle under influence of all the hormones, LH, luteinizing hormone. And after ovulation happened, this ova releases, and this follicle remaining, it become corpus callosum, undergoes fatty changes, and it releases progesterone. It's the main source of progesterone for 8 to 9 days, and it causes changes again in endometrium, secretory changes in endometrium for these 2 weeks. If pregnancy happens, then it continues releasing the progesterone. But if pregnancy not happened, then it disintegrate this corpus luteum and to corpus albicans, and menstruation happened. And again, the cycle begins. So this is here anterior pituitary. Anterior pituitary, it releases under influence of hypothalamus. It releases FSH-LH that influence the ovaries and testes, growth hormone that influence the growth of bones and tissues, and the prolactin that will affect the mammary gland of breast, and adrenocorticotropic hormone that affects adrenal gland cortex, and thyroid stimulating hormone that controls the thyroid gland. These all hormones released from anterior pituitary. And then posterior pituitary, it releases 2 hormones: oxytocin that affects mammary gland and uterus, and antidiuretic hormone that affects kidney tubules. So menstrual cycle, it has ovarian cycle, uterine cycle. So ovarian cycle, where development of follicle happen and ovulation happens under influence of hormones, and uterine cycle, functional endometrium thickens and sheds. So changes are functional here, and then they are hormonal changes. So two-cell theory. What is two-cell theory? Inside the ovary, we have cortex, especially we have theca cells and granulosa cells. Granulosa cells, they have receptors for follicle stimulating hormone, and theca cells, they have receptors for luteinizing hormones. So under influence of hormones, granulosa cell, they make estrogen and release in this bloodstream, and luteinizing hormone, under influence of luteinizing hormone, theca cells, they produce androstenedione under influence from cholesterol, and that androstenedione undergoes changes in a granulosa cell under influence of follicle stimulating hormone and release estrogen in the system. This is two-cell theory. GnRH is a decapeptide that releases from arcuate nucleus, and it affects the pituitary and help in releasing FSH and follicle stimulating hormone and luteinizing hormone. They travel through hypophyseal portal vessels to the whole body, especially affects the receptors in ovary. So GnRH release is pulsatile fashion, usually 90 minutes, 60 to 70 minutes. In first half of the cycle, they release like frequency is more, but amplitude is less. But in second half of cycle, frequency is less, but amplitude is more, like they increase in higher amplitude. Steroidogenesis will not go in detail. Progestins, we already discussed. They needed in second half of cycle. Then follicular development, how it happens from primordial follicle. You can see here, this is primordial follicle that converts into primary follicle, then mature follicle, and then here ovulation happened, ova releases that disintegrates to corpus callosum with fatty changes. If pregnancy happened, it continues to grow, continues to release progesterone. But if pregnancy not happened, that it disintegrates and make corpus albicans. So in menstrual phase, endometrial cycle. In menstrual phase, there is disruption of endometrial tissues, WBC's infiltration, the RBC's extravasation, proliferative phase. There's estrogen-induced proliferation. In secretory phase, there's progesterone-induced secretion of glycogen, mucus, and other substances. So let's start with history and examination. Once the patient, in a gynae patient, always you will greet the patient, introduce yourself to the patient, ask her initials about her name, age. Age is very important because if you're dealing with before menarche, after menarche, adult woman, or a postmenopausal woman, perimenopausal woman. And then occupation, if it is she's a housewife or a working woman, marital status, husband's name, or age and occupation. Then ask for chief complaints. In gynae, usually we receive patient with bleeding, irregular periods, discharge, mass in abdomen, abdominal pain, prolapse, or urinary problem, sexual problem, or infertility issues. So you will go according to the chief complaint in detailed history. Menstrual history is very important in gynae patient. Ask for age of menarche, cycle regularity, days of flow, heavy flow change. If she is having heavy flow, number of pairs she is changing, any flooding on passage of clots. What was the last menstrual period? Any pain during periods, or low back pain, or dyspareunia if she is married. Then obstetric history, ask for the number of children she is having, mode of deliveries, any complications, antepartum, intrapartum, postpartum, and a last baby, and a weight of baby, previous births. And then contraception history is very important, if she is taking any contraception or no, and what are her future plans for pregnancy. Then ask her about pap smear if she has done it, and when she has done it, whether it was normal or abnormal, whether she has undergone any treatment. And then past medical history, always to rule out if we are giving any medication, to know that if there is any interaction. And surgical history, if we are planning for any surgery, we should know if she has undergone any surgeries before, especially on abdomen, so that we can plan it. Family history, especially other than medical issues, if she is having any ovarian, breast, and colon malignancies in the family, first degree relatives, second degree relatives, allergies to medications and drugs, or any food allergies. Then drug history, if she is taking any. Now, gynecological examination always ask the patient the permission for examination. After you will take vitals, general physical examination of hands, mucous membrane for anemia, supraclavicular lymph nodes, thyroid gland should be palpated, chest, breast, and proceed for abdominal and pelvic examination. Abdominal examination, ask the patient, take the patient to couch and cover her appropriately, and then ask her to undress from her abdomen herself, starting from inspection for any changes, skin color changes, distension, and striations, any mass, any abnormal movement, and then palpation. Before starting palpation, warm your hand and ask the patient if she is having pain. If she is having pain at one place, then start from opposite area to avoid that tender area, and examine that tender area in the end, and percussion if needed, and auscultation if needed. Pelvic examination, always ask consent, a verbal consent from patient. Always you should have one chaperone available with you by the time you are doing examination. Even if you are a female, you should be with a chaperone or midwife or a nurse while you are examining patient. Examination starts with the inspection of external genitalia. Ask the patient to strain or cuff while to demonstrate any incontinence, if it is she has any complaint, or she is old age patient, or any prolapse. Then we will proceed for speculum examination according to need, and bimanual or digital examination. Speculum examination according to indication. If the patient is having vaginal discharge, any prolapse, or any bleeding, any contact bleeding like postcoital bleeding, you need to assess the cervix. And any indication for cervical smears, and you should explain the patient if you are going to do cervical smear, and explain that what will be the procedure doing cervical smear, and she might expect some bleeding or spotting after the examination, especially pap smear examination. Routines. What are the indication for speculum? Again, prolapse, postcoital bleeding, menstruation. I already discussed with you all this. How to prepare? Again, verbal consent. Ask the patient to empty her bladder, and look at separate private area for her to undress, and chaperone should be available. Again, you should have gloves available, disposable surgical gloves, and speculum available. Speculum, it can be univalve or bivalve, Sims or Cusco's speculum. Lubricant jelly, examination couch, modesty sheet, adequate lighting, and light is important because you are examining inside the vagina. You should have proper lighting there. Ensure speculum is warmed while you are inserting. So while examining, separate the labia minora to expose introitus. After taking verbal consent, inspect the clitoris, opening urethral and vaginal, and any and vaginal mucosa, whether it is well estrogenized, poorly estrogenized. Well estrogenized mucosa will appear as pink colored, thick texture, rugosity will be present, folds. And poorly estrogenized will be thin, pale colored, absent rugosities in postmenopausal, especially if there is any vaginal discharge, color, texture, odor. And older women, ask her to cuff and demonstrate incontinence. This is the speculum, Cusco's speculum, bivalve speculum, whatever you say. So this is metallic one. These are the blades. When you will introduce, you will close the blades and enter. In nulliparous, usually you enter it vertically initially. After entering, just rotate it, bring the valve up. If she is on supine position, up, and open the valves. If she is multi, like she has children's before, then you can introduce even horizontally. That's she will not feel any pain. While you will examine the patient, you will assess that it can be done vertically or horizontally. So it should be pain-free, like painless, while you are introducing speculum. Always lubricate your finger, lubricate your speculum with KY jelly. It should be available all the time. Inform the patient sterile duct bivalve Cusco speculum. And then before inserting, you should always check if the screw is working and it's working, it's in working condition, not rusty. Then after lubricating, you will insert and open the valves inside and visualize. You will visualize the cervix. What is the type? It's small, round in nullipara and slit shape in multiparous. What is the color of cervix? If any secretions discharge, any ectropion, any ulcer, any cervicitis, any Nabothian follicles are there, or any growth or cauliflower-like, or any bleeding, contact bleeding, ulceration, scar inside. And if needed, you can take the pap smear. From there, we'll discuss how to take that. So to take pap smear, it's you have different type of spatulas. This is Ayers spatula, this is brush, cytobrush Ayers, and they are different. Like I don't know if in your area if they are using still slides or they are using thin prep. Liquid based cytology is the best one. Nowadays, they are using liquid based cytology because here it's 90% sensitivity is good, better than the slide. And because the slide preparation is in the laboratory, you will just prepare and shift it to laboratory and they will prepare the slide there. And high sensitive, its liquid based cytology is highly sensitive in detecting cervical intraepithelial neoplasia. How to use that thin prep? This brush, you will just apply gently, brush, thin brush here, and then rotate it 5 times clockwise direction, never go anti-clockwise after you finish. Then take your broom and swirl inside the bottle for 10 times vigorously so that all the material, it will go in the bottle, all the cells. So pap smear will be prepared and inform the patient she will be coming after 10 days or 1 week for the result, always. So pap smear result may be normal. Normal doesn't mean that she is off, like she is 100% guaranteed she don't have CS cervix, but it will just suggest that patient has less chance of developing this, but she will continue having her routine screening according to her age, 3 yearly or 5 yearly. If it is inadequate, then we have to repeat it in 3 months again. If it is abnormal, then again, if it is minor changes, then we have to repeat it in 3 to 12 months. If it is major changes, then we have to refer her immediately to colposcopy unit. So again, come back to, we finish with cervical examination. Now come to inspection of vagina. With the speculum in position while you are removing, you can see on the sides, the vaginal wall, skin color, discoloration, discharge, any growths in the vagina. While you are removing, withdrawing the speculum, gently inspect her anterior and posterior vaginal walls as well for any changes, and you have to mention it in the notes. In patients who are presented with prolapse or cystocele, or then we can do it in lateral position by Sims speculum. Ask the patient to lie on her lateral and bend her legs against the chest and assess her anterior wall first and posterior wall first with the Sims speculum. After you finish with the speculum examination, then comes digital examination or bimanual examination. Again, use the KY jelly, introduce your index finger first and then middle finger, and assess and palpate all the vagina, lateral fornix, cervix, especially if cervix is firm, no, open, close. And along with that, while you are examining the vagina and cervix, you will put your left hand, if you are right-handed, left hand on abdomen to press and assess the size of uterus. And you will assess laterally from lateral fornix adnexus if there is any mass, tenderness, and move the cervix right side to side to see any cervical excitation to rule out ectopic or acute PID. And consistency, if you found any mass or uterine enlargement, then assess it according to, like at the level of umbilicus, it's 22 weeks. So just above the symphysis pubis is 14 weeks, 16 weeks. So assess it accordingly. And then if there is any mass, then consistency, size, position, mobility, and tenderness. Once you've finished the examination, then pouch of Douglas, of course, for any nodularity, for especially in tenderness, especially in cases with the endometriosis. So after you finish your vaginal examination, you remove your hands, explain, cover the patient, explain her the findings, and write down, record your findings. How? Start in this manner: vulva, vaginal, cervix, uterus, adnexa, and any additional significant findings. I've gone through all this Hutchinson's clinical methods and South African family practice manuals and Google images for examination because we cannot express. I hope I have gone through all. If you have any question, I'm ready to answer. Otherwise, I'm just closing the recording.